Thank you so much for carving out the time in your day to join us. My name is Kat Lukacs, and I'm Muso's Major Gifts Officer. And as you know, Muso works to cure delay in healthcare. I'm pleased to welcome you and spend the next hour or so together. Today, we're here to share about Muso's new health clinic in the community of Yurimajo, and more specifically, Bakoro Babugu. The concept for the clinic began several years ago as a response to the community's need and the severe overcrowding of Yurimajo's one single existing clinic. Over the past 10 years, Yurimajo's population has grown from 20,000 to 200,000. And you can imagine how this has overtaxed the health system. It has resulted in long lines for patients, delayed care, and in many cases, lack of care because some patients simply don't have that time to wait out, and overstressed providers that cannot keep up with the demand for health services. You will hear the term SESCOM used, and this is referring to a primary health clinic in Mali, with a coalition of support from foundations and individuals, community groups, the Malian government, and Mass Design Group. Muso has gone from concept to construction, and now we are very eager to open doors to patients. On our agenda today, we'll hear from our Chief Medical Officer, Dr. Jessica Beckerman, who will talk about health systems and share why it's vitally important to assess care on all levels of the system in order to cure delay. We'll also hear from our urban site coordinator, Dr. Mariam Cissé, who will tell you the story of how specific key partners came together to realize this idea, as well as showing us inside the clinic. And lastly, we'll hear from Larry Gilson at Focusing Philanthropy, our partner for this campaign, who is matching all donations at a 1-to-2 ratio. And he'll talk about why his organization chose to support Muso on this initiative. Before we get started, just a quick housekeeping item. We do have a chat feature open for this call. If any questions arise during our time, put them in the chat. We'd be happy to follow up with you individually after the event. We might not answer them during the call, but I do encourage you to use the chat for any reactions you may have throughout our time. For example, if you hear something inspiring or moving, let us know, shout it out. If you feel compelled to give, share your commitment, or even just introduce yourself and where you're logging in from. We'd love to hear from you, our community of action, for which none of this work would even be possible. So let's get started. I'd like to introduce Muso's CEO, Dr. Ari Johnson, who would like to say a few words to you all.
Thanks, Kat. And thank you, Larry, and Focusing Philanthropy for partnering with us on this exciting campaign. Huge thanks also to Mass Design Group, our partners in designing this new center, which is about to open. So, and thanks to all of you for being here with us. All of us are here together because we share a common commitment. We share a commitment that no one anywhere deserves to die waiting for care. No one should have to wait in their suffering without getting the care that they need. So as we chase a cure for delay, as we chase this vision of early healthcare for everyone, we know that that path requires us to solve a big problem. And that problem is how to provide early universal health care to rapidly growing urban areas. More than half of us on Earth live in urban areas today. And between now and 2050, the African continent is going to be the fastest urbanizing area in the world. Nowhere will be urbanizing faster. So when we think about that, when we think about folks leaving the support of their families and their social networks in rural areas, arriving with very few resources newly into cities, and settling into peripheral urban areas with very little in the way of infrastructure and support, solving for this, creating a vision and making that vision real for what does early universal healthcare look like in these urban areas is critical. This is the project that we've taken on in partnership with the communities of Yurimajo. And it requires a whole array of things. It requires deep community partnership. It requires close work together on proactive outreach and proactive registration, making sure every patient counts and no one falls through the cracks. And it requires a continuous evolution of the infrastructure available for patients. And we'll hear a lot more about this over the next, over this hour that we have together from some of our amazing teammates and partners. So thank you for being here. Thank you for your commitments and for being on this path with us. And thank you to Focusing Philanthropy for being our partners in this critical fundraising and matching campaign.
Thank you, Ari. And next, I'd like to introduce you to Dr. Jessica Beckerman, who is Muso's Chief Medical Officer and co-founder and technical guru of all of Muso's health programs. She's going to help us understand how accessible and rapid quality care at the primary care level fits into an overall health system. So Jess, thank you for being with us.
Thanks, Kat, for having me. And I also want to echo Ari and Kat's gratitude to Focusing Philanthropy for this really incredible opportunity to partner together.
Great. Jess, to begin, I'm wondering if you could talk about your early observations of maternal health in Mali and what a pregnant woman's experience might be like.
Sure. I think of my neighbor and now my good friend in Mali, in Yurimajo, let's call her Aminata. I met her in the 3rd trimester of her pregnancy when she was sick with malaria. And we were living at the time in this dense urban area right on the edge of Mali's capital city. And she was acutely malnourished and hadn't seen any healthcare professionals during her pregnancy since she had no way to get herself to healthcare. And frankly, even if she could, she wouldn't have been able to pay for it. By literally just by the sheer force of her will, she was feeding her family by washing clothes, and that the healthcare that she needed for herself and her unborn child could not be unlocked by any amount of tenacity on its own. And she really played an important role in teaching us what it means to provide rapid, universal healthcare in a rapidly growing urban area. She needed a community health worker, and she also needed a nearby clinic with accessible care, with quality care. The lifetime risk of maternal death in Mali is 29. This is an indicator that's published by the World Bank for each country that is defined as the probability that a 15-year-old girl will eventually die from a pregnancy cause. To put that in context, in the United States, that number is 3,000. And let me add that even 3,000 is unacceptable, and that is mostly because of racism. In Italy, that number is 51,300. Yeah, so in Italy, 1 out of 51,300 women will die from pregnancy, and in Mali, 1 out of 29 women will die from pregnancy. And I mean, so you imagine you're sitting in Mali in a 10th grade classroom full of 29 15-year-old girls, and one of them is going to lose her life because of pregnancy. So I just imagine facing pregnancy in Mali and wondering if you're going to be that one. And so my early observations of maternal health in Mali just put face after face to those numbers. And the thing is that pretty much all of these deaths are preventable with tools that we have had for nearly a century or more: antibiotics, blood transfusions, cesarean sections, blood pressure medicines. And this kind of care is provided mostly by midwives and nurses and doctors. CHWs play a necessary role, and CHWs must be able to proactively reach out to people in their homes and then connect patients to good clinics and hospitals if we're actually going to move the needle on maternal health. So although the core of Muso's health system is our CHW model, and we can't get very far without CHWs, we also can't get very far without clinics and hospitals working effectively in collaboration with our CHWs. My mentor, Joya Mukherjee at Partners in Health, says that maternal health is the report card of a health system. And that's because you can't just do one thing. Like, you can't just make sure CHWs are doing a great job teaching everybody in their communities around pregnancy danger signs. Although that is absolutely critical and you need that community care, you also need primary care and you also need emergency obstetrical care.
Okay, thanks for articulating that. So if maternal mortality is the report card of a health system, can you break that down for us? How does Muso approach that?
Sure. We build a health system that has all of these levels: community care, primary care, emergency care. Community care, this is our community health workers. They have intimate relationships with their communities. They meet patients where they live. They make home pregnancy tests available. They identify pregnancies early. They connect women with prenatal care in the first trimester. They make sure that people have the transportation, the other logistical support to get to their prenatal care. And they recognize danger signs. They help with breastfeeding. And this is the core of the Muso model. And then primary care happens in clinics like the one we're talking about today. And this is where most obstetrical care happens and where most of it should happen. This is nurses and midwives who are providing prenatal care, who are taking care of women with relatively normal births. Primary care is really all about preventing complications and identifying complications when they do happen, like making sure every pregnant woman takes malaria prevention meds and has a bed net. This is malnutrition treatment, which improves outcomes for both the mother and the baby. It's early screening for diseases like syphilis that when they're treated early in pregnancy can often prevent congenital malformations. It's regular screening for blood pressure problems so that when they arise, they can be treated early before causing life-threatening complications. And so this clinic level, this primary care level is where we can prevent and then identify and provide first-line treatment for complications like infections, hemorrhages, labor obstruction, blood pressure problems, diabetes in pregnancy. And so there is where we triage these problems and we make sure that emergency evacuation is available to a higher level of care. Emergency obstetrical care, this is typically district and national hospitals that we collaborate with. And this is where labor obstruction is managed. If somebody needs a cesarean section or an operative vaginal birth, if somebody needs a blood transfusion or is septic and needs acute management of that. And when these services, this more complex emergency obstetrical care is not available, this is where women die. And so when we say that maternal mortality is the report card of a health system, we're really looking at all of these levels of the system.
Okay. So community care, primary care, emergency care. So all these levels are important. But if you were to pick the level of care that was most critical and deserved the most investment for maternal care, what would you prioritize?
I would say we have got to be working to raise the standard of care on all these levels. It's not an issue of do this or that. It's an issue of do this and this and this. Otherwise, women die. And you can't just do one thing. You can't just do one thing well. You need to have quality care on all of these levels for maternal health.
Okay. So we can't ignore any level of the health system. We have to work on all levels to improve health outcomes. And you mentioned quality care. What kind of investment does that look like? For Muso, can you describe like the work or input into the system that we focus on with quality?
Absolutely. You know, I've seen, unfortunately, a lot of us have seen a lot of terrible care that has passed as maternal health care. We can talk about what percentage of the population in a country like Mali is only it's 5 kilometers, for example, away from a maternity post or a community health center, who's only X amount of X distance away from a skilled birth attendant. But then when you actually walk into a lot of facilities, it's clear that the care is completely unacceptable by this century's standards, or frankly, even by standards from last century, and that it shouldn't pass at all as a skilled maternity facility. So I'm talking about a room that we call a community health facility with a rusty bed and a bucket and no light, that's staffed by a very junior provider who doesn't have the training or the support to manage most of what they might encounter. I mean, who would want to go to such a place to give birth? especially if you had to walk a few miles there in 100-degree weather and then pay for it with money that you didn't have. I mean, personally, I would rather give birth at home. So if we're going to talk about common decency and dignity for all women, regardless of where you live in the world, the kinds of standards we need to be talking about are things like, is the facility clean? Do providers have a place to wash their hands? Is there a working blood pressure cuff? Are there providers with the appropriate training and the necessary support that are available? Or is everybody getting routine episiotomies, routine bladder catheterization during birth, even though the scientific evidence and the recommendations everywhere say don't do this? Ability to manage hemorrhages. Are the core essential medicines available to stop hemorrhage? And do the birth attendants have the support and the equipment and the training to be able to manage and at least to triage a life-threatening hemorrhage? Is there essential laboratory testing and imaging available for pregnancy? Is there a system for emergency evacuation? And is there respect for patient privacy and consent? Is this a place where somebody would have a positive experience? So physical infrastructure, equipment, supply chain matters, training and mentorship matters. And most of all, care has got to be affordable. And in most places, that means it has to be free. There's this story in the international development world that this kind of complex care that we're talking about, blood transfusions, C-sections, that it's not cost effective, that $20 or even $100 for maternity care for a pregnancy is not efficient or sustainable. But there's this devastating double standard. And I gave birth in the Bay Area in California last year, and we got a $18,000 a day bill, after which my insurance company completely covered. We don't hesitate as a global community. We don't blink an eye to pay for maternity care for some people. And yet the ways that we value people's lives or don't, the ways that we define who receives care and who won't receive care as a global community has got to change. And this is why we at Muso, we see this story of maternal survival as a human rights issue, fundamentally as a justice issue.
Thank you, Jess. So ultimately, we're working for greater health justice, improvements in maternal and child health and survival. As our teams prepare to open clinic doors in Bakura Babugu, how do we elevate the standard of care at the onset?
Great question. And it's such an exciting moment to be able to watch that start to come into fruition. So this new facility has been designed by our partners, architects at Mass Design, who truly have been able to create a facility that supports patient dignity and supports care quality. And there are showers for laboring and postpartum women. There are private birthing areas rather than everyone being in one big room all together. The clinic will be staffed by qualified providers. There are dedicated spaces for hand washing, and there's hand sanitizer on the wall. There are postpartum hemorrhage emergency kits. And we have a clinical training and mentorship program, a clinical quality improvement program that we run with our government partners at all of our partner clinics, but that will be a part of the culture of this clinic from the moments that its doors are open, which is the first time that we've been able to see that. And I'd also add that we've been talking a lot about maternity care, but this clinic will provide more than that. It will do vaccine distribution. It will provide primary care and essential meds to adults, to kids. It will provide urgent and emergency care. And at the end of the day, we have got to just be investing in health systems in the places where the system has been the most neglected. And the site for the clinic that we're building in partnership with Mali's government here in Bakura Babugu, it's one of the poorest neighborhoods of Bamako. It's one of the fastest growing cities on the planet. And until now, women facing situations like my friend Aminata didn't have a good option. And I truly believe that this clinic is going to transform that for Bakura Babugu. It's an opportunity to respect the immeasurable value of every human life, to elevate the standard of care, and in the end, to do what we're here for in the first place, which is to fight injustices of healthcare.
Jess, thank you so much for talking with us and helping us understand how the clinic connects with all these levels of the health system and the incredible efforts already made through the design and planning of the clinic.
Thank you, Kat. Thanks everyone for joining us.
Okay, so next, I'm thrilled to share with you my colleague, Dr. Mariam Cissé, who's our urban site coordinator and who has been instrumental in conceptualizing the idea of building the clinic and also pulling together all the necessary partners so that it might actually become a reality for our patients. And on a personal note, I will just say that Dr. Mariam truly embodies the spirit of Muso. And by that, I mean she leads with her heart and does not hesitate to reach for the most ambitious goals for our patients. I'm so grateful she's taken the time to share her story of how this clinic came to be. And this is a recorded interview from Mali, so I'm going to bring up my video and screen share.
Moi, c'est Madame Diallo, Dr Mariam Cissé. Je suis coordinatrice des sites urbains de l'ONG Muso. Mon travail, c'est améliorer la santé, l'améliorer en général les activités de Muso sur les sites de Irimadio. La vision de Muso, c'est vraiment rapprocher les soins à la communauté. L'une de nos indicateurs phares, c'est la vitesse. Qui dit vitesse dit connexion rapide au service de santé. Certes, Irimadio est un milieu urbain, mais il y a des quartiers qui sont très éloignés du centre. Maintenant, en plus de ça, le design de la ville fait qu'il n'y a pas de moyens de déplacement interquartier. Donc, le moyen de déplacement, c'est vraiment sur la voie publique, mais il n'y en a pas interquartier. Il y a des populations qui sont servies dans l'heure de santé de Irimadio, mais qui sont à 6 km de l'heure de santé de Irimadio. Donc s'ils doivent se rendre au centre de santé, ils doivent venir à pied, ils doivent chercher des moyens pour se déplacer. Bakorobabougou est un quartier de Irimadio, dans lequel Muso opère. Tout travailleur à Muso, nous sommes dans la communauté, donc j'ai fait beaucoup de sorties dans la communauté et lors de ces sorties, nous demandons à la communauté qu'est-ce que Muso peut faire pour améliorer encore l'accès aux soins. Donc c'est comme ça qu'il y a beaucoup de personnes dans la communauté de Bakorobabou qui ont dit vraiment le centre est loin d'eux, surtout les femmes. Pour faire les CPN, parfois quand tu as 7 mois, 8 mois, 9 mois de grossesse, c'est pas facile de marcher. C'est pas facile de monter sur la moto et les véhicules se font rares. Donc parfois il y a des dames, quand le travail commence, vraiment elles savent même pas comment aller au centre de santé. Donc c'est ce qui fait que certains accouchent à domicile, certains accouchent même dans les véhicules, les taxis qui les amènent au centre de santé. La personne des ressources même au niveau de Bakorobabougou, dont le quartier même porte le nom de son père, était vraiment celui qui nous a beaucoup appuyé dans l'approche communautaire pour que la population puisse adhérer à cette idée. Une fois, j'ai parti chez lui pour faire une rencontre autour de ce deuxième CESCOM. Directement, il y a un monsieur qui est venu l'appeler pour dire que sa femme est en travail. Et malheureusement pour nous, la femme était jusqu'à la phase d'expulsion. Donc nous sommes partis chercher la femme. Et façon dont la femme, comme je suis médecin, je connais déjà les signes du travail. J'ai demandé à la femme dit, elle a envie de pousser. Donc moi je lui ai dit, on ne peut plus arriver au centre. Donc nous avons été obligés d'amener la femme dans une clinique. Elle a accouché dans la clinique et nous avons cotisé entre nous pour payer les frais d'accouchement de la femme. Mais si le CESCOM était à Bakorobabougou, ce jour-là, la femme n'allait pas autant souffrir et allait accoucher avec des sages-femmes en qui elle a confiance. Parce que c'est sera avec des sages-femmes avec qui elle avait commencé les soins prénataux et c'est sera avec ces mêmes sages-femmes qu'elle allait accoucher. Parce que l'accouchement, il y a la confiance qui est là. Quelqu'un que tu n'as jamais connu, chez qui tu n'es jamais parti, si tu dois aller chez la personne pour accoucher avec tous les risques qu'il y a, c'est vraiment difficile. Voilà, ça c'est un fait réel que moi-même j'ai vécu. Et la dame là, ces jours-là, sur la table m'a dit, Madame, on m'a dit que vous travaillez à Demain, comme Muso, on appelle Muso dans la communauté Demain. Faites tout pour que notre centre puisse voir le jour. Sinon, nous, on souffre ici. Donc, imaginez un peu, si cette dame-là avait accouché à domicile, avait eu des complications, même si elle a accouché au centre, si elle n'était pas, s'il n'y a pas de personnel qualifié, parce que nous ne connaissons pas la qualité du service offert dans cette clinique-là. Et si elle avait une complication, si elle avait une hémorragie, je ne saurais pas si on allait pouvoir gérer. Donc on a quand même fait avec tous les risques, mais aujourd'hui la femme quand même va bien. Maintenant, par rapport au temps d'attente, j'ai été témoin de ça plusieurs fois. Il y a des dames, c'est les femmes qui doivent préparer à domicile. Ce sont ces mêmes femmes qui font les travaux ménagers et ce sont ces mêmes femmes qui amènent les enfants au CESCOM pour avoir des soins. Donc imaginez une femme, elle amène son enfant, elle vient au centre à 6 h du matin, croyant qu'elle va finir vers 8 h, aller acheter les condiments pour aller préparer pour les restes des membres de la famille. Et si cette femme, au lieu de quitter à 8 h, quitte à 14 h, imaginez tous les problèmes sociaux qui sont derrière. En plus de cela, il y a eu aussi des gens qui sont venus en bonne santé. La maladie n'était pas grave, mais le temps qu'ils ont fait pour attendre, ils ont eu vraiment, ça a été des évacuations même. Parce qu'ils ont perdu connaissance sur place, on a été obligé de les évacuer directement et ça a augmenté le coût de prise en charge. Parce que si on avait pu voir cet enfant-là dès à son arrivée, on allait pu faire la prise en charge au centre ici, au lieu de l'évacuer sur la structure supérieure. Voilà. Maintenant, au CESCOM de Yirimadio, vu le nombre d'AEC qui couvrent le CESCOM de Yirimadio et la population couverte, nous avons de plus en plus de nombre de consultations élevées. En moyenne, en 2020, nous étions aux alentours de 5300 consultations mensuelles. Donc, ce qui fait au minimum, nous avons 5 médecins ici qui font la consultation, ce qui fait au minimum 200 patients par jour, soit 40 patients par médecin. Donc, Muso, c'est vrai, nous voulons amener les soins à la communauté, mais nous voulons amener des soins de qualité à la communauté. Donc, pour même désengorger les centres et réduire surtout les temps d'attente des patients, parce que ce n'est pas du tout facile de venir depuis le matin pour les soins et repartir jusqu'à 8 h après ou 7 h après. Ce n'est pas du tout facile, ça ne répond pas à notre critère de vitesse de prise en charge. Donc c'est ce qui fait que nous avons vraiment eu beaucoup d'arguments pour avoir un deuxième centre. Donc je peux dire qu'il y a eu 3 acteurs clés. Il y a l'équipe Muso, il y a l'équipe gouvernement, il y a l'équipe communautaire. L'équipe communautaire, et ils ont vraiment fait l'engagement autour de ce projet. C'est eux qui ont cherché tous les documents administrative pour la réalisation de ce projet. De la création de l'ASACO, qui est l'organe de santé communautaire, à la création, à la recherche des documents, c'est eux qui ont donné les terrains sur lesquels nous avons construit le centre de façon gratuite. C'est eux aussi qui ont fourni la main-d'œuvre pour pouvoir appuyer l'entreprise qui va faire la construction. Ils sont allés même jusqu'à faire la prise en charge alimentaire des manœuvres pour que le chantier ne s'arrête pas du tout. Il y a l'équipe du gouvernement, notamment l'équipe du CCRF, qui est le district sanitaire dans lequel se trouve le centre de santé, nous a beaucoup facilité la réalisation même de ce projet. Parce que c'est eux qui devraient valider la SACO, c'est eux qui devraient valider même le projet de construction, parce que c'est eux qui vont intégrer cela dans leur microplan national. Parce que quand le centre va fonctionner, c'est eux qui vont amener les vaccins, c'est eux qui vont amener les médicaments, c'est eux qui vont assurer la formation des personnels techniques du centre à travers l'équipe Muso, avec l'appui de l'équipe Muso. Maintenant, le partenaire Muso a joué vraiment le rôle clé. D'abord, le premier rôle de Muso, ça a été l'orientation de la communauté vers l'obtention des documents administratifs. Deuxième rôle, ça a été vraiment l'obtention du fonds nécessaire auprès de nos bailleurs pour pouvoir débuter le projet. Dieu merci, le projet a vu le jour. Donc, nous sommes à la phase de construction. Bientôt, le bâtiment sera fini. Nous devons aller maintenant vers l'équipement de ce centre qu'on va appeler l'opérationnalisation. Et l'opérationnalisation va comprendre l'équipement et le fonctionnement. Le fonctionnement passe par le recrutement de personnel. Certes, l'État va fournir des personnels, mais ça ne sera pas suffisant pour couvrir la population qui sera soignée dans ces centres. Donc, Muso doit venir en appui à l'ASACO pour recruter d'autres personnels, en plus de ce que l'État va donner pour pouvoir continuer l'offre de soins. Aussi, Muso va appuyer cet ASACO à faire une bonne gestion du centre. Et pour cela, Muso sera obligé d'amener des logiciels, d'amener des systèmes, de mettre en place des systèmes de gestion et d'approvisionnement qui vont permettre à l'ASACO de vraiment bien s'en sortir, même sans l'appui de Muso. Donc nous pouvons dire qu'on a fait beaucoup de choses parce que le bâtiment vraiment a vu le jour, mais nous avons plus à faire pour rendre fonctionnel ce centre. Et il ne s'agit pas de rendre fonctionnel, mais il s'agit aussi de maintenir le cap. Parce que tu peux les rendre fonctionnels aujourd'hui, si les ressources font défaut demain, ça peut tomber à l'eau tout ce que tu as réalisé. Mon espoir ne sera pas pour Bakorobabougou seul, mais ça sera pour la population de Yirimadio. Donc, cette deuxième clinique de Bakorobabougou va soulager au moins un tiers de la population de Yirimadio. Et ça va nous permettre de faire la qualité, ça va nous permettre de donner la qualité des soins à la population, les soins de qualité à la population. Donc moi, mon espoir pour cette population de Bakorobabougou et de Yirimadio, c'est que chaque personne puisse avoir l'accès aux soins sans être fatigué, puisse avoir les soins à temps et les soins de qualité à temps. Moi, docteur Mariam, je suis née dans une famille très pauvre. Mon papa n'avait pas de ressources financières de façon mensuelle. Mon papa était ouvrier. Il était mécanicien de moto. Ma maman est ménagère. Donc, elle aussi, elle n'avait pas de source de revenus. Donc, notre première intention dans le traitement, c'était vraiment traditionnel. Donc, pour manque de soins, moi, j'ai perdu 2 sœurs. C'est ce qui fait que je suis fille unique aujourd'hui. Certes, j'ai beaucoup de frères, mais je suis fille unique pour ma maman et pour mon papa. Et si moi, j'ai la chance aujourd'hui d'offrir des soins à des personnes qui sont dans la même situation que j'étais avant, même si moi, je n'ai pas de ressources financières au bout, j'ai la satisfaction morale et je sais que j'ai servi à quelque chose. Et c'est là, à travers l'organisation Muso et à travers tous les donateurs, nous parvenons à faire de ces rêves, ces grands rêves que j'avais étant enfant, qui étaient de soulager tout mal pour mon prochain, est devenu réalité aujourd'hui. Bienvenue au CESCOM de Bakorobabougou, dans la communauté de Yirimadio. Voilà, ici c'est la salle d'accouchement. Nous nous sommes inspirés de l'expérience de Yirimadio pour pouvoir vraiment garder l'intimité des femmes. Nous n'avons pas voulu faire une grande salle, nous avons fait des boxes d'accouchement. Ici, ça peut prendre 4 femmes en même temps et chaque femme verra vraiment son intimité respectée. Ici, c'est la salle d'hospitalisation. Avec l'avènement de Covid, nous avons vraiment pensé à agrandir cette salle pour qu'il y ait au moins 2 mètres, sinon minimum 1,50 m entre chaque lit, parce que cela peut nous permettre de garder la distanciation et aussi de respecter l'espace de tout patient. Comme dans notre vision et mission, nous battons pour l'équitabilité. Donc pour cela, nous avons tenu aussi à faire une rampe pour ceux qui seront fatigués en prenant l'escalier, peuvent monter par la rampe, mais surtout pour les personnes handicapées qui auront besoin de roulettes, de chariots pour pouvoir monter et venir faire leurs consultations et leurs analyses biochimiques en haut. Oui, ici c'est le laboratoire. Avec notre programme d'amélioration de la qualité, tout patient qui sera traité au centre sera fait sur la base de la confirmation. Donc pour confirmer les examens cliniques, nous devons aussi faire des examens biochimiques pour pouvoir confirmer le diagnostic du patient et poser le bon traitement. Je vais pouvoir donner de l'espoir à des femmes, je vais pouvoir donner de l'espoir à des chefs de famille et je vais pouvoir donner la chance à des enfants de fêter beaucoup d'anniversaires. Merci à Muso, merci aux donateurs.
Okay, welcome back. I hope you guys can see me again. Great. So I hope you know what I mean about Dr. Mariam being just extraordinary. All right, so now that we've seen the clinic, we've learned how essential it is for the community of Bakoro Babugu and Greater Yurimajo to have this clinic in order to provide rapid care and prevent unnecessary death. And furthermore, how access to quality primary health care fits into the structure of a strengthened health system. It is time to talk about what's next. So construction is complete thanks to the major support of both foundations and individuals. And in order to open clinic doors and serve patients and fully operationalize, we need medical supplies, equipment, medicine, electricity, water, patient beds, and resources to train community health workers and clinicians. We need these pieces in place in order to open clinic doors. And as you know, at Muso, we are all about speed. So any delay is a potential life lost. We are very eager to resource this clinic as quickly as possible. The last person I'd like to introduce you to is Larry Gilson at Focusing Philanthropy, our fundraising partner, who has set up a campaign to match donations in support of the work ahead. Focusing Philanthropy will match all donations over $1,000 at a rate of 1 to 2. So every $2 that Muso raises, his organization will contribute an additional $1 towards the campaign. Larry, thank you so much for being with us today and sharing a bit about Focusing Philanthropy.
Well, thank you, Kat, and thank you so much for allowing me to participate in this event and to really get the inspirational message that has already been communicated. I think in order to maybe help explain how we fit into the equation, I'll say a few words about Focusing Philanthropy and how we came to support Muso and why. For the past 10 years, we've been seeking out and supporting demonstrably effective, scalable responses to some of the most difficult human challenges, both in the United States and internationally. Today, over 400 families, foundations, and companies use us as a free resource to support a portion of their philanthropic giving decision-making. Last year, these generous donors have helped us advance the objectives by contributing over $30 million, which we deployed in support of programs of our 14 implementing partners, of which Muso, of course, is one. Since our inception, we conservatively estimated that the generosity of the donors who we relate to have supported programs that have changed the lives for good of over 6.3 million people in the United States and the developing world. But we all know that there's more work to be done. The approach that we take is to identify a serious area of human need that we think lends itself to private philanthropy. Not everything does, but where things do, we want to find the most effective ways to proceed. We recognized quite some time ago that the community health worker model held great promise as a way to project high quality, respectful healthcare to chronically underserved populations. And as we watched the sector evolve, we saw Muso emerge as a leader in terms of the human impacts that it was delivering in the communities served, in terms of the measurement and evaluation and rigor by which it evaluated and thereby refined its own programs, in the success that it achieved in engaging with and partnering in a credible and respectful way with the national ministries of health, and in the ways that other nonprofits were looking to Muso as a model of excellence. So these observations led us to engage in our own intensive diligence process that culminated with our deploying a team from California to Mali to visit Muso's programs on the ground, to interact with Muso staff, to interact with some frontline community health workers, government representatives, and program beneficiaries. And what we saw then, and what we continue to observe through our ongoing monitoring, which is continuous, is that Muso is in fact a leader in the field and a model for others. We also observed on our site visits to Mali the very clinic that's overtaxed and with lines out the door and with a difficulty to accommodate all of the growing population that's needed to be served. And when our team returned, their comment was that they shared the view that they heard from Muso's staff on the ground, that a second clinic needed to be a top priority. Frankly, we probably would have launched this campaign a year earlier if it weren't for the COVID pandemic. But last year, we partnered with Muso to provide additional support, resources, and training to community health workers through Muso in Mali to address that emergency need. The need has not gone away, but of course, neither has the need for the clinic. So we're especially excited now to be able to partner with Muso, and hopefully many of you on this call, to finish the job of equipping, staffing, and preparing the new clinic, the second clinic in the district, so that it can open as soon as possible. We have the same sense of urgency that Muso has communicated and lives by, so that it can serve areas not easily covered by the one existing clinic. It can make the existing clinic more effective by dealing with the overload that's currently there that can be redirected. And also in the current pandemic, to provide another hub from which COVID vaccinations can be administered. So speaking for Focusing Philanthropy and our generous supporters who make this matching challenge possible, we're really delighted to have the opportunity to advance the important work that Muso is doing every day to serve the people of Mali, and through that experience to demonstrate to other organizations in other countries what's possible, and to give a path to a better life for people who were just simply dealt a tough hand. I hope that you'll join in this effort by responding to this challenge. Thanks, everyone.
Thank you so much, Larry, for your support and your longstanding partnership. I wanted to highlight that at this moment, with a goal of raising $1.1 million, we are 75% there. And we're very grateful for the generosity of many of our partners already. I wanted to name Yasha Hoffman, the Canib family, the Ripple Foundation, and the Campbell Family Foundation, who have already committed their support. And now it's time to close up. I wanted to thank you all so much for being here, for showing up and being with us in this commitment to cure delay as a cause of death. By recognizing that delay is one of the world's greatest but most preventable problems in saving lives, you become part of the solution. So thank you for your partnership. And thank you to the panelists. Thank you, Larry, once again. Thank you all of you for being here. To support the campaign is in the chat box where you can donate directly. And also this event has been recorded. So if you'd like to share this with anyone in your networks, we'll be following up with that as well. And my email is in the chat box. So please feel free to contact me directly. Thank you all.